Hello, everyone. Good morning. And thank you for being here on the last day of the conference. So I am very happy and doubly honored today to be standing here to introduce this year's Lobsky Lecture at the 20th anniversary of the Genomics of Rare Disease Conference. So this conference has a very particular space in my heart because I've been here, my first time was when I was in my last year of undergrad. And then later on as a Lobsky lab member, I was able to come several times to present work and posters on structural variation, personal genomes, and genomics of rare diseases. And now being part of the organizing committee and presenting this lecture on this anniversary occasion, it's really great. So, I'm sure Jim would have loved to be here. Unfortunately, he couldn't join us this year, but I think we'll feel his presence when we come to this conference, and so he's very missed. And therefore, as a Lobsky Lab graduate, I'm very happy to be here introducing this lecture. And the second honor is, of course, to introduce Dr. Wendy Chung as our lecturer. So Wendy has had a long trajectory in rare diseases, from her contributions to identifying genetic causes of different rare diseases, to her advocacy and support of families, and more recently as a leader and pioneer on implementing genomic newborn screening in the US, and sort of now this trend across the world. So Wendy is chair of the Department of Pediatrics at Boston Children's Hospital, and she's also a member of the Harvard Medical School faculty. And I've known Wendy for almost 14 years now, so it's a great privilege to introduce her as this year's Lobsky Lecture speaker. Thank you, Wendy.
Thanks, Claudia. I'm thrilled to be here today, and I'll tell you about what's been really an evolution in our thinking. Just to declare the conflicts, this is who supports the Guardian study. And in thinking about this, this journey for me actually started a long time ago with phenylketonuria. It was as an undergraduate that I really, as a biochemistry major, that I got the bug in terms of understanding inborn errors of metabolism. And before the Human Genome Project even started, I realized how much of my time was being spent in genetics and genomics. And it was really from that time that I started thinking about the public health infrastructure for what we could do. And it's taken a long time to be able to get to where we are, but with this, I think we are at the precipice of some opportunities, but as you'll see, I think we've got a lot of learnings to do as we go. The next step for me within that journey came as we'd been studying within the Pediatric Neuromuscular Research Network a condition called spinal muscular atrophy. Many of you know about that. It used to be, past tense, the most common genetic cause of death for children less than 2 years of age. And it was at that time where we were looking at the natural history, and it was very clear to all of us that you had an early decline, and with that decline, it was loss of the motor neuron cells, and with that, it was a one-way street. You couldn't get back those motor neurons once they were dead. And so as I could see that the first clinical trials were coming forward with ASOs, I became quite concerned that if we didn't get to individuals pre-symptomatically, that is, if we started treatment after the loss of those motor neurons, we wouldn't be able to demonstrate efficacy, or at least not very robustly, and the sample size required would be ginormous. So I came up with a suggestion, which was a little crazy at the idea, but proved to be quite useful, which was how are we going to identify individuals pre-symptomatically? The genetics of this are very simple. For this autosomal recessive condition, 95% of individuals have the same SMN1 exon 2 deletion. And so I suggested that we had a consented research study using the residual dried blood spot from newborn screening, and we actually genotype everyone for that one mutation, knowing that we would be able to pick up most individuals. And with that, it wasn't simply diagnose and then adios, but it was diagnose and then offer individuals, and this is a little counterintuitive, but entry into a clinical trial, what at the time was an ASO. A little counterintuitive because newborn screening is predicated on this idea that you screen for something that has an approved effective treatment. So this was paradigm shifting in the idea there would be entry into a clinical trial. Of course, not required, but an opportunity to do that. So as we did that when I was in New York State, and it proved to be quite effective in terms of the uptake rate being 92% for parents that wanted to do this. We got the cost of screening down to 21 cents per baby, so it was incredibly cost effective to do this. And it did prove that those early children identified from the newborn screening, if you look at the New England Journal of Medicine paper for nusinersen, they are the best performing in terms of the best outcomes. So in fact, that hypothesis proved to be correct. Showing you, and just the proof is in the pudding, this was the first little girl we identified for the newborn screening. She would have had type 1 SMA with 2 copies of the deletion and 2 copies of SMN2. She went into the clinical trial, and otherwise, usually by this age, she would have been deceased, but instead she continues to be a very healthy, strong, robust child who's had no issues whatsoever in terms of problems with weakness, problems with respiratory insufficiency. And in fact, she was part of the package that ultimately did this very rapid back and forth. So what I mean by that is, as we then had from the pilot study data that the pilot study worked, that is that technically it worked, the uptake was high, and we then had with her data FDA approval for the first ASO study. We were then able to go to the so-called ACADUNC in the United States, which is the advisory board that reviews the evidence for adding conditions to newborn screening. And with that, we actually had approval to add that to the recommended universal screening panel. With this and with Cure SMA, the patient advocacy group, in record time, we actually implemented across the United States and now increasingly around the world, actual implementation, so really doing it across the United States. And we now have not just 1, but 3 FDA-approved treatments, including one and done, so to speak, gene therapy for SMA. And as we do this, we really have implemented and completely changed the natural history of this condition into a very different outcome. So it was with that study that we then went on to do some additional pilot screenings for newborn screening. We next did Duchenne muscular dystrophy in the United States. As you may or may not know, we now have added that as well to the recommended universal screening panel. And as we were doing this, though, I could tell that each time we did one condition, it was incredibly laborious. That is, the amount of energy, time, cost that went to adding one condition by one condition was simply untenable as I started thinking about the number of conditions to come forward. So it was at that point that I went back to our families in our SMA newborn screening study. And I went back not to the families who had a child that was positive for SMA, but I went back to all of the negatives. And I started having discussions with them about if it were up to you to plan what a newborn screening study would look like, or what you would want your child screened for, tell me about what that is and what it isn't. And so it was really over a period of 3 years, through many, many discussions with them, that the families designed what is now the Guardian study, Genomic Uniform Screening Against Rare Diseases in All Newborns. The idea behind this is relatively simple. It's a consented research study where we take the residual dried blood spot, so we take what is already taken from the child for newborn screening. We work very closely with the Department of Health in going forward, and as you can see, we developed a very close working relationship with them with the other pilot studies, and we perform whole genome sequencing, not because we read everything out, but it gives us the flexibility of the platform to be able to be nimble and to be able to, as new conditions have FDA-approved treatments, we can then add conditions or, in some cases, subtract conditions if they're not the conditions that should be on. It also gives the ability to store those data. So we actually do this in a CLIA-CAP laboratory or a clinical laboratory, and we store the data so that beyond Guardian, if a child should become symptomatic, they can go back and in not a screening mode, but now a diagnostic mode, they can go back to those data and get a diagnosis based on what their symptoms are. All of this with my effort to be able to leave no child behind. That is, doing this within the public health infrastructure is meant to be a system, and I'm going to emphasize that a couple times, meant to be just a system where it just happens, where it's robust, where it's reliable, and it has fewer points of failure as we go forward. So it was within this that we did it very intentionally, as I said, as a research study to gather the evidence to understand at a population level as well as at an individual family level. And I'll tell you some of those stories so that you'll get a sense of what it really is like from the perspective of the families. So the bottom line is, okay, Wendy, you can do this whole genome sequencing. How do you operationalize what we actually return to families? And I'll say that we've done this in stages. In the earliest stages, I wasn't sure how well this would work. We started this in New York City as an example. It's a very diverse community, and as you'll see, I'm very glad to report that we represent that diverse community. But as we do that, I didn't know if we'd be able to do it. I didn't know how long it would take us to do. So we started out relatively modest with about 250 conditions. That was in version 1. We've since gone up and almost doubled that to 450 or so conditions in version 2, and we're getting ready for a version 3 that has refinements yet still. All of this, though, is information that's what I call news you can use. So all of this is actionable information. The core is a group of what I call group 1 conditions that have approved, effective treatments that are available and a way of being able to confirm the diagnosis before treatment is initiated. All of these conditions either have symptoms or require action before 5 years of age, so it's meant to be conditions that affect young children. It's not meant to be conditions over the lifespan. It's meant to be for in a similar way to what we do with traditional newborn screening. In addition to that, for individual alleles, and I will get into it's the individual alleles and then even genotypes as well, we were looking for conditions that are highly penetrant, and we operationalized that to a penetrance, at least based on the published literature, of greater than 90%. We realized the literature lies in the sense that once you do population-based screening, you realize that, in fact, there's a wider spectrum in terms of individuals with the penetrance and expressivity, but we're uncovering that over time. And within this, we had some very robust arguments, or discussions, I should say, among families about how actionable is actionable enough in terms of treatment. And one group of conditions in particular that families surfaced were conditions associated with epilepsy. And the reason this got discussed was because epilepsy, certainly early recognition is important and oftentimes not recognized early enough for maximal benefit. But many of these conditions still associate with neurodevelopmental issues longer term, despite even optimal treatments of the epilepsy. And whether or not families wanted to know that information on a little tiny baby was something that they were thinking about. So we made that optional in terms of those conditions. Group 1, core conditions if you come into Guardian, and Group 2, optional in terms of whether or not you decide to do these. So to give you an example of what some of these are, and I'll go into even more detail, these are, as I said, for Group 1 conditions, not only the traditional inborn errors of metabolism that we see with many of the things in traditional newborn screening, but also inborn errors of immunodeficiency, cardiac conditions, neurological conditions, as you'll see, hematological conditions, and then Group 2 being those associated with epilepsy. At the end of the day, I'll just sort of steal one of the punchlines, is that most of the parents who decide to join also do Group 2 conditions, about 92, 93%, so the vast majority of families decide to do both. When we decide what to report, so the individual variants, this is something where, again, in a New York City population, we had to make some decisions about how to be able to be inclusive. And looking at studies that have now sprung up around the world, different groups are choosing different pipelines to do this. And I'm not critical of any one, it depends on what your constraints are. But we could have limited this to just pathogenic or likely pathogenic variants, as an example. And that certainly is the most sort of high throughput workflow to do this. But again, being in New York City, where many of the true disease-associated alleles would be currently classified as variants of uncertain significance, I felt uncomfortable doing that. I felt that that was not going to be equitable, and that we needed to actually force ourselves to do the hard work and to be able to surface what the challenges were going to be. So ultimately, we came to a compromise. That is, for conditions where we had just one allele, we would limit that to path or likely path. But where we had two alleles, we would take one of those two alleles as being a variant of uncertain significance based on prediction models that might predict that it was going to actually be disease associated. And that was a compromise, knowing that we would have some false positives in going forward. And in fact, that's the case. We do have false positives. But again, forcing us to be able to deal with the real world challenges. So we've currently screened over 25,000 newborns. I'm going to report the data today on the first 15,000 where we have long-term outcomes, so I can tell you the whole story. But this is a continuously, as you'll see, we continue to follow the children over time to understand those outcomes as well as to look for false negatives that we may have missed. Within this, in the New York City population, it's a majority minority population. So we have about a third of individuals who are white of European ancestry. But importantly, we have 2/3 that are from all over the world. And that's been important in terms of pushing us. The uptake is about 73% of parents who are offered to do this actually decide they do want to do this. This is a process where we start the education prenatally in a passive sort of way. We give them information with their delivery packets. And then we have someone come to the bedside postpartum to be able to tell them about the study and explain and answer any questions that they might have. And then we give them up to 30 days after birth to make a final decision. Although most of them decide if they're going to do it, they actually sign the consent prior to discharge. As we do this in English, Spanish, as well as Cantonese and Mandarin, and have individuals who are native speakers to talk about this and from the community, and I will say not professionally genetically trained until they come into the study. As we do this, going forward, most individuals are deciding to do both of these if they decide to enter the study. What are the results? We end up with about 3% of individuals currently with screen positive results. This number has actually come down over time, despite the fact that we've gone up in terms of the number of conditions. And as I'll be showing you, that's because we've learned ways over time to reduce the false positives. And so as we've done this, again, the total positives decreased, but the percentage of true positives increased as we've gone forward. Showing you on the right, most of the positives that come forward are these group 1 conditions, so that's the vast majority of what we see. And of those, and I'll go into more detail, G6PD is the most common of all of those coming forward. As we do this, and before we start any intervention, we do confirm the diagnosis through an orthogonal method. For now, most of this is done based on doing it outside of using the dried blood spot, but we do blind ourselves to the results of regular newborn screening. And so we do this in parallel. Regular newborn screening goes first, so if you have hypothyroidism, phenylketonuria, sickle cell disease, any of those usual conditions, that goes first, and we don't slow that process down. I'll also say that the whole process of Guardian has not in any way decreased the uptake from regular newborn screening, so that's all gone on uninterrupted. We independently look at the results from Guardian, and then before we call the families with results, we harmonize those results to make sure that that makes sense and that the families won't be confused. In addition, if the condition is not on regular newborn screening, we, under the study and under the cost of the study, do the confirmatory test or parental testing that we might do, for instance, to understand phase. So for instance, for recessive conditions, we would have 2 alleles, but with short read sequencing, we don't know the phase, and so we use the parents to be able to understand that. We cover the cost of testing for that. And then as we go forward, we also cover within the study what I call onboarding to care. That is referral to the subspecialist, working with the pediatrician. And once we have the family placed with the treatment, then we let go but continue to follow the outcome for the child. All of this, as I said, very much coordinated with our standard newborn screening program in the State Department of Health. So as we do this, just to show you that the vast majority of results are positives, but we do have a small number of group 1 conditions as well as group 2 conditions that are not confirmed. The group 2 conditions, I've realized over time, are a bit more complicated, and I'm happy to answer any questions that might come up in Q&A about that. But the point is that of the conditions that could have been and should have been detected by newborn screening, it's actually the minority. Most of these that are not detected are G6PD deficiencies, and I'll go into that in a little bit more detail. This is just to give you an example of what we've learned over time, and in some cases we've learned very, very rapidly. Cystic fibrosis for us is part of traditional newborn screening. Within the first 1,000 cases, we had 11 cases of individuals who had 2 variants that were both predicted to be pathogenic. We very quickly, once we started doing phasing within the community, realized that these 2 variants were on the same haplotype. As we even looked back at the founders, we could see the original founder haplotype that this went with, and realizing that these were actually just carriers. That is, they wouldn't really be predicted to have cystic fibrosis, and in fact had normal immunoreactive trypsinogen or normal newborn screening for this, then removed this from the pipeline so that this was reported as simply 1 allele, 2 variants or 1 haplotype rather. So in doing that, that's just an example, but one of the examples we had from the learnings as we go, and some of these that are things that weren't, for instance, in ClinVar to be annotated as such, but important to do as we've surfaced the international community that we have. This is what I mean by looking at regular newborn screening. So all of these conditions should have been detected by the regular newborn screening. But there are cases where we had false negatives essentially from regular newborn screening. And this is a way to synergistically enhance what we're already trying to do. And so you can see their improvements over time. Not surprisingly, as an example, sickle cell disease, something that's easily picked up by regular newborn screening as well as Guardian. Hearing loss as an example, and I'll point out, I didn't actually put it in the slide deck because it's so new, but newborn hearing screening is done physiologically. So we're actually doing, being able to look and see if we see the electrophysiological signal of hearing. One of the things that we've realized over time is that, for instance, there are some genetic forms of hearing loss where children may pass their regular newborn screening physiologically, but where the hearing impairment comes on over time. So the prime example and a critical example now, otoferlin, and I say this because just last week, new FDA-approved gene therapy for otoferlin, but this is one of those cases where genomically it actually ends up being a better screen, or at least a complementary screen to what we see with the electrophysiological screening as well. Let me go into a little bit more detail. I'll go into some of these cases, both of SCID and of G6PD deficiency. So G6PD deficiency, probably many of you know, is actually one of the most common, if you will, genetic conditions that we see worldwide. As we look at it around the world, it also affects mostly underserved communities in terms of individuals of African ancestry, Asian or Latina ancestry. The condition itself results in hemolytic anemia, oftentimes with a trigger that triggers this, but in particular for newborns, they can have jaundice or kernicterus. Kernicterus being actually damage that can be done to the brain as a result of that. And for many of us as pediatricians, neonatologists, we do have robust systems of being able to recognize the jaundice, the yellowness in babies, and have whole protocols for phototherapy to be able to eliminate this. Within this, and again, this is an X-linked condition, that won't surprise you that most of our individuals are males, but we also have a fair number of females that have either one or two, either compound heterozygotes or homozygotes for this. And as you'll see, not surprisingly in terms of the distribution, similar to the distribution of what we see worldwide. Because of the common, the frequency, the high frequency of this in New York State, where we started Guardian, it's interesting that there was a state law that was passed along with newborn screening about how this should be screened. In this particular case, the screening is mandated to be done at the hospital. So not at the central state newborn screening program, but at the level of the hospital. And it's not that it should be done on everyone, but the regulations in terms of doing this are based on family history, clinical factors, or race or ethnicity. In doing this, unfortunately, as you'll see, this isn't a very robust or reliable system. It depends on the individual clinician or hospital to make a decision about how to implement this. And unfortunately, this is just many, many points of failure in terms of being able to set up a system. This has been set up. I will give credit to the Mount Sinai system that's not in Guardian in terms of doing this, but they have set up a separate system to be able to do this that has been more robust and reliable than, to my knowledge, any other hospital system within New York State. So as we did this, one of the challenges in doing this is then figuring out what alleles to report. So we decided initially to report out anything that was pathogenic or likely pathogenic in going forward. And this was based on WHO criteria that have looked at the enzymatic activity and that correlation. And so as we've done this, I'm showing you the distribution, and I'm showing you because if any of you happen to be particularly interested in this, it is a very, very common condition, and as a community, we've got to make some decisions about whether this is something we include or something we don't include. I will say that based on the Guardian data, it's a small number of children who as neonates will have hemolytic anemia. So in doing this, it's a very small fraction of those who end up being positive. And within this, if one, and for timing of results in terms of this, we're getting the Guardian results in about 3 weeks. But this is usually after discharge and after the time of jaundice. And so if one really, really wanted to implement this, as it is done in some parts of the world, one would need to take a cord blood sample and do the testing as point of care in the hospital within the first 24 to 48 hours to be able to implement that care prior to discharge. Otherwise, this is mostly about lifelong health. It's not mostly about newborn health. And so as we're thinking about what to implement, how to implement, where we put it in the electronic health record, these are some of the questions we're starting to think about and grapple with. Do we report out all variants, just the ones with the most severe deficiency? Not entirely clear to me yet. Let me give you another example, though, of something where it has been much, much more impactful. Within regular newborn screening, we try to include severe combined immunodeficiency, and we do this with the so-called TREC assay, the T-cell receptor excision repair. As we do this, this little boy actually passed his TREC assay with newborn screening, but when we did his sequencing, we saw that he had an IL-2RG mutation. As we started working that up, we tested his parents. This is an X-linked condition. It's a de novo mutation, explains why we saw no family history. And then we started working him up from a physiological point of view to understand the functional implication of this, and saw that he had a problem in terms of functionally with the STAT5 activation as well as lymphopenia. All this while he's still sitting at home, healthy and without any infections. With this, now having evidence in terms of both the predictions at the variant level as well as looking in the literature and realizing that we had case reports of 2 individuals with the exact same variant and looking at their clinical outcomes. One of the children had died of disease. The other child had an overwhelming infection, but his life was saved with a bone marrow transplant. So looking at that data, individual level data from this child, publication data we had from other case reports, we brought together a group of subject matter experts in inborn errors of immunodeficiency from around the country, got them to review the data with us and to weigh in and make a recommendation. And their recommendation was unanimous that he should have a bone marrow transplant. This is ideally done before there's a severe infection. And so in his case, we started the workup. We were able to identify a sibling who would be a good donor. We kept him safe, literally in a bubble to prevent infection until that time. And he went through a successful bone marrow transplant and to this day continues to be healthy and has never suffered a severe infection. He even has a younger sibling who's been in Guardian as well. So this is one of those cases that we were trying to identify. The intervention, though, not trivial. A bone marrow transplant, not trivial, but the impact, I would argue, potentially life-saving. So what are some of those other conditions that are not necessarily part of standard newborn screening, but the expansion that we're trying to do? I'll give you some of the examples to show you the richness, but a fair number, and this is the frequency on the y-axis here. The frequency, a large number of conditions that affect the heart, inherited arrhythmias, a fair number of inborn errors of metabolism, immunodeficiencies you've heard about, as well as conditions like achondroplasia, hypochondroplasia, as well as some kidney conditions. So let me give you some of the richness of what we've been observing. Long QT syndrome are those cardiac conditions that I alluded to. We thought the population prevalence was going to be about 1 in 2,000. That was based on the literature. We're finding that the prevalence is more like about 1 in 800, at least based on the genotype. Again, that's maybe not surprising that we oftentimes find when we do population-based screening that it's more common than we expected. This has turned out to be interesting in the sense that just to be full disclosure, there are people that argue back and forth about whether or not this is useful. This can be associated with sudden death, can be associated with SIDS or even sudden death in infancy, but it's very preventable. By avoiding some of the triggers that bring this out, this can be a very effective intervention. And for certain individuals, not just avoiding triggers like medications that prolong the QT, but being more proactive by using a beta blocker as a cardioprotective can be very effective. And beta blockers are very inexpensive, well-tolerated medications. In addition, just facts about this condition, it's often, but not always, autosomal dominantly inherited. So by surfacing this information, you may surface information that's relevant to the child, but also to other family members, parents and siblings as well. So in doing this, I didn't know exactly what families' response to the information was going to be, but it's been quite informative actually working through this and seeing how they respond. So number one is I'd say it's been greatly successful in terms of the sort of how much the families appreciate the information and how little the burden has been. So let me just walk you through this. When we identify this and call this out to the families, we're able to bring the baby in and very quickly do an EKG. EKGs, just in terms of implementation, generalizability, you can do an EKG almost anywhere in terms of being able to do this. You get a very quick readout in terms of what the QT interval is. The QT interval itself actually helps you in terms of risk stratification. The longer it is, the higher the risk is. We're able to send those EKGs centrally to a pediatric electrophysiologist for a second opinion. This can happen literally within minutes in terms of doing this. And in doing this, you can go from giving information to being able to give a plan of action to the family very, very rapidly. And being able to do that, and I emphasize the rapidity and the generalizability for doing this, that's proven to be very important in terms of not leaving parents in a period of anxiety. And that, I think, in terms of long-term implementation is important. As we've done this, just to give you a sense, and we're following the children over time because the EKG can actually change over time as well. But right now we have about half the children who are sitting in an area where, again, this community will understand. QT intervals are a distribution. I'm not showing you the absolute distribution here, but clearly what you're doing is shifting that distribution over to the right. So not everyone is over the threshold of liability, at least in terms of their QT interval. But what we're watching and waiting to see is whether by avoiding things that may trigger this, will we in fact avoid the sort of stochastic individual times where they might pass that threshold of liability. In doing this, we do have a small number of children who have clearly very prolonged QT medications, and as we've done that, put some of those children on beta blockers, as well as with the cascade family member testing, identified some family members that need to be treated with beta blockers, and even some families with sudden cardiac death, or at least I should say sudden death of unknown etiology. This is an example of something fairly common. The intervention, I would argue, fairly well tolerated, and the uptake rate and acceptability fairly high. Let me give you another type of example. This is a condition, retinoblastoma. This is a baby where we identified an RB1 mutation, identified that it turned out to be de novo, perhaps not surprisingly. And for this condition, which predisposes to tumors within the eye, we put the baby under anesthesia to be able to get a good look at the eye. And when we did that, the first examination at 6 weeks of age, we already saw bilateral retinal tumors. We were able to go in and cryoablate those tumors and save vision and start the chemotherapy that's necessary with that treatment and continue to follow that baby long term. And perhaps not surprisingly, as we've continued to do the exam, continued to see new tumors arise, continue to go back and cryoablate them early, continue to save vision as we're going forward. But just an example of this, a type of thing that would not have come up until very late in disease when it usually does, and oftentimes losing vision at that time. So again, especially for these de novo mutations, there's no other warning, and unfortunately other screening is not as effective. This is a particular child with Batten disease. In this particular case, these are the mutations shown here for those of you interested in that. Interestingly enough, and I go back to this because we've been talking at this meeting also about preconception or prenatal testing. In this particular case, the mother did have carrier screening, and this was not identified on her screening, and that's in part because of the alleles that are seen. We went back after we saw the genetic results and did enzymatic testing. We've done that now both on the dried blood spot to be able to understand if we can use that dried blood spot to be able to do confirmatory testing. I also double-checked also in terms of doing that also with whole blood to look at the correlation between those two, and as you can see, they correlate very well. This is one of those cases where there is an FDA-approved treatment in this condition associated with neurodegeneration. So it's an inborn error where you have the enzymatic deficiency that over time there's accumulation, which essentially destroys the brain and destroys neurons. On the other hand, pre-symptomatic treatment with the enzyme replacement therapy avoids that damage to it's irreversible. So as we did that and understood that and confirmed the diagnosis and I'll say educated the family, they were willing to accept the treatment, again, prior to symptom onset. This requires enzyme replacement therapy directly into the brain every 2 weeks. So this is not trivial in terms of the intervention, but again, profoundly changing in terms of the disease trajectory. So we've now embedded an Ommaya reservoir to be able to more easily do this intervention, and the child continues to be asymptomatic and doing well, but on the enzyme replacement therapy. This is a child with metachromatic leukodystrophy in this particular case, and we've even been talking about it here at this meeting with homozygous ARSA-A mutations. Again, I'll emphasize that this child's parents actually had parental carrier screening and was actually identified both parents as being carriers prenatally. They declined prenatal testing with this information, but we did confirm after the genetic results to also do enzymatic testing, which you can see the severe deficiency. For this condition, which is predicted to have early onset disease, the therapy in this case is a gene therapy. It's FDA approved, and in the United States, this requires ex vivo gene therapy. So we actually have to take the bone marrow cells out of the body, treat them, and then go back. So this requires busulfan conditioning as an example. It's not a trivial intervention, but with this, pre-symptomatically, this child is now undergoing the final stages of gene therapy for this condition as well. So let me switch now for a second to the group 2 conditions. These are these neurogenetic conditions associated with epilepsy as well. One of the things that's been interesting, and I'll have to say that I continue to wrestle with this, is these group 2 conditions. I anticipated the disease variants would be de novo, or else the parents would be symptomatic. And in fact, we do have a very high frequency of these that are de novo, and we have now electrophysiological ways by 3 months of age, by eye tracking and EEG, to be able to robustly predict those individuals who are going to be severely symptomatic. I'll just say for those of you who are interested in the complexities, there are also some of these that are inherited rare variants that I do think are also going to be disease associated, but may not be as severe in terms of the disease that we're seeing, and being able to understand, therefore, which conditions, which alleles to report is going to be a little bit more complicated. As we've been doing this, just to give you a sense, we continue to follow these children over time, as I said, both the positives and the negatives, to understand the medical impact for the children, but also the impact on the families. So as we do this 30 days after disclosure of results. I'm interested in understanding the acute response, mostly of the families, in terms of what they're doing, where they're getting their information, who they're believing with the information they get. And then we follow them every year on their birthday. So being able to understand long-term outcomes, we look at the medical records as well as have the family report on how they're doing, and then do semi-structured interviews beyond the surveys as well as focus groups to be able to understand how to improve the study as we go forward. In doing this, we're understanding, I think, many diverse experiences, and this has been incredibly important to understand that it's not one size fits all, both because of the conditions that are returned, but importantly because of the differences by families and how different information use the information, how they access care, what their access is to care, the supports that they need going through. And one of the things we've definitely appreciated is during this process of confirming results and onboarding to care, we had to expand our team, which we've done and did so very quickly. That includes a genetic counselor, a geneticist, the pediatrician for the family, sometimes the obstetrician, the specialist, a patient navigator, a social worker, but a whole team really to be able to support the family, as well as, very importantly, and this was something that's been important, the patient advocacy groups are very important, but it was important to actually have what I call the welcome wagon, with people who really understood that the journey in coming through newborn screening is very different than the journey after a long diagnostic odyssey from someone who's been symptomatic. And so that's been, I think, is still going to be an important part of what we need to build in terms of infrastructure to make this work. Quantitatively, just to give you a sense of how families are doing with this, we use a common measure, a decision regret scale. This is in the negative. I will say in the positive, families feel incredibly empowered, both those who get negative results as well as positive results. A score greater than 25 on a decision regret scale is something that gives me concern. At least I want to understand that better. And so as you can see, whether it's screen negative or screen positive, the vast majority of individuals doing well. Although I segmented this to see if there was any signal at all that we needed to be paying attention to. And as you can see, the group 1 results doing very well. The group 2 results, a little bit more concern. This is 30 days. And so this is what I call an acute response to the information. We continue, however, to follow individuals at their first birthday. So here's the acute response right after we return results, and then longer term with the adjustment. And importantly, that group where I saw the signal I was a little concerned about, the important thing is that they're adjusting to the diagnosis. That regret is coming down over time. And what many of them have started to appreciate over time is how empowered in knowing that information has been helpful. And actually, by seeing other families who didn't have the benefit of that, they're sort of post hoc realizing what situation they're in. And so, and also I hope they continue to be supported as we're going forward. So just in terms of wrapping up what we've learned so far, what I would say is overall we've learned many things, and literally at least once a week I learn something new from our families. In doing this, I think there's overwhelming support in terms of both families with positive and negative results, although doing this, I will say we've done it with white glove service. So we've done this, I think, fast enough that we could see the pain points, but slowly enough so that we could fix the pain points as we went forward. And I think that's one of the lessons that I've learned in terms of being able to hopefully implement this on broader scale as we go forward. As we've done this, there are a lot of people that just have no idea what regular newborn screening is, needless to say, have no idea what genomic newborn screening is, and so it's really surfaced for everyone, I think, the need for public health education, and I'm waiting still for what I call our Angelina Jolie moment about when it becomes a matter of public discussion about what this is, and I do think that's going to bend the curve in terms of, hopefully in a positive way, appreciating what the opportunities are. As we've done this, I think there are multiple ways that we could go. I will say no one is perfect within this whole process. We've surfaced issues at the diagnostic lab, the clinical lab. We've helped them to be able to improve their pipeline, their workflow in terms of variant interpretation and individual personal analyst review. And I will say our biggest point of failure is actually people, not machines, in terms of doing this. And so as one lesson learned, to be able to continuously improve that are things that we're doing. As we're going forward, I also think, as I said, in doing this, it's been, I give most of the credit to our staff that have done this. They're incredibly mission-driven people that came from our community, that care deeply about the community, and them being the ones as ambassadors to the program, I think has been some of the secret sauce in moving this forward. As we go forward, I'll just say that we're learning around the world. So although Guardian has done a lot of this, and I feel sort of embarrassed coming to the UK to be able to talk about this, because in many ways what's going on here is going to, I think, be hopefully incredibly informative to what we're all doing worldwide to be able to make this go forward. But I can see the opportunities literally just in the 3 years that we've been doing this about new treatments that have become available, opportunities to flex and flux, and it makes me even more convinced that we need to have a flexible platform where continuing to revalidate the assay over and over time is not needed, and as we can use the data that we've collected to be able to inform and prepare and do some test cases before launch and implementation of new conditions. So just finally, really the credit goes to all of the fantastic people that collaborate with me on this, and I'll be glad to pause here for questions.
Thank you, Wendy. If we have questions, also a reminder for people online to write their questions. There's one, Hillary?
Well, no, I have one, but someone else. There's nothing on that.
Oh, there.
Thank you, Wendy. A fantastic talk and really exciting endeavour. The G6PD results were really interesting, and I wondered if you'd also considered other pharmacogenetic genes being included on that screen, and whether long-term, over the baby's lifetime, they would know what those results were, so that any time they were prescribed something, they would, that would be considered.
Yep. So yes, we've definitely thought about G6PD as in part pharmacogenetic and then going more broadly. So the feedback and my concern in each healthcare system is unique in this, is that you can't do one part of the system without the other parts of the system. And so we don't have, and I'm embarrassed to say this, but we don't have the most robust system for pharmacogenomics that are following the patient over their lifetime. And without that, I actually worry that it's a disservice potentially to the systemness as a whole. On the other hand, if we had that within the electronic health record and the prescribing system, and that's why I'm a little bit jealous about other countries where you can just hopefully do things more easily and universally. If you had that whole wrap around to be able to do this, yes, I think flipping that switch makes sense. I don't know how to do this, and I don't frankly know how to save people from problems that might ensue if you only do a part of the solution but not the whole.
Thank you.
We have one from online.
There's two, actually. The first is about, it's from Thiloka Radnaki, and the question is about whether you collected socioeconomic data on the participants and whether educational background influenced the uptake or understanding of the risks and benefits.
Yeah. So in terms of uptake, we have segmented to understand by hospital, by self-reported race, ethnicity, and by insurance type, whether or not we see any bias, and based on that, we don't have any bias. I didn't put it in this deck, but we asked people who don't come into the study why they don't come into the study, and largely it's because they just don't want to do research. It's not specifically issues about genetic privacy or other things. There are limitations to what you can collect in people who don't come into studies, so we are limited in terms of not doing complete surveys to figure out, for instance, educational attainment.
Helen?
Hi, Wendy. Fantastic talk. Thank you very much. Mine's more of a comment, really, which is that I think you illustrated how you relied on the literature to inform your management of the child in whom you're going to undertake a bone marrow transplant. And I just think this ups the game on all of us to continue to write case reports, to continue to put data into databases, to define the natural history of these conditions, and particularly at a variant level, because this sort of mission going forward will very much depend on us gathering that knowledge base. And so we can't just pivot from, we'll just flip everything to newborn screening without taking advantage and building on the legacy and the knowledge which collectively we all accumulate, but which we're actually quite poor generally at sharing, because that's what this is going to depend on going forward.
So I completely agree with you. I'll also say that, frankly, I'm worried about not just who comes to clinical attention and gets in the literature, but I'm worried about who doesn't and actually is asymptomatic. And so if I could argue for anything, and this is US-centric, we have all of us as a way of having somewhat population-based data, and all of us knows that I say this. It's only some of us, and it's very depleted in terms of children right now, and I think that's a limitation in terms of desperately what we need for pediatric conditions to be able to inform these decisions. So quite frankly, anywhere around the world, I think we need these population-based data as much as we can with the outcomes.
Hillary?
I was quite shocked and also impressed at your guts at deciding to include the VUSs when there are second hits or second conditions. And I wondered if, what are your lessons from that? Do you have a sense of what proportion of those have turned out to be pathogenic? You don't know the testing and so on.
Yep. Maybe it was fool's errand, but so we've done an analysis, and I should have thought to put the slides in this deck, but we do have a manuscript under review specifically about this. So number one is that as we short read sequencing, but due to, and thanks to Caitlin Samocha and her group for coming out in terms of being able to make predictions about which variants were likely to be in cis versus in trans, we've added that to the pipeline, and that's helped significantly in terms of even before we do parental testing. That's the best in terms of for recessives being able to help us. I'll also say that we suffer both ways, that if we hadn't included VUS, there's some very significant diagnoses we would have missed as predicted. On the other hand, it's about 50-50 in terms of also having ones that end up being nothing, if you will. But I thought it was important given the implications and, like I said, forcing ourselves to do the hard work to be able to force ourselves to do that. Through what many of you are doing and through the new guidelines, ACMG, AMP guidelines that I think will come up for variance interpretation and new methods of prediction for missense variants in particular, I think we're going to get more and more robust as we go forward. So I actually would encourage us to push ourselves, whether we do it just because we're doing it on a research basis in parallel or we're doing it in real time and reporting results out to families. I don't think we can not do it and ensure equity.
We have one there, and then we'll come back online.
Great work. I was very encouraged by your engaging with parents, and you find a lot of buy-in. I'm just wondering about the other group that needs to be on board, which is institutions and the political system. And could you comment a little bit about the challenges, barriers for that, and whether you've done any microcosting studies from a health economic standpoint in order to push this forward into implementation?
Yeah. Institutions are important because it doesn't cost them anything and we do all the work. So from that point of view, I don't think that's been a problem, and I think they've actually been supportive. We have done, starting to do economic analysis in terms of this. There are some important levers that determine the outcomes. Not surprisingly to this group, the cost of sequencing itself is the biggest driver in terms of what cost. There are the interpretation, the reporting, another portion of this, but the actual sequencing cost itself is the biggest driver. Interestingly enough, on the outcomes, what is one of the biggest drivers in outcomes is what you assume the value of a life is and what you do in terms of the implications for families, for a child with disabilities, and what the impact is for them, not just from a healthcare cost, but what it does in terms of parents' productivity, mental health, all the rest of it. So depending on what value you assign to that, it very clearly is a population benefit in terms of doing this, but depends on a value system.
We have an online question.
There's a question from Nina Larson in Lund about the variants associated with non-QT. Were the US included with the variants classified according to ACMG? She's very surprised at the high prevalence.
Yeah, so just to be able to explain, so long QT is a dominant condition driven then by heterozygotes, just one variant, so that's limited to path or likely path. We don't put any VOs in for that.
Wendy, I was wondering if you could speak to the regret scale in the group 2 conditions, many of which are probably neurodevelopmental epilepsy conditions that we all study, and kind of have you explored that? Is that relating to knowing your child's not going to be normal? How does that adjustment happen?
So we've looked at that. We've looked at individual level people to understand that, and people can disagree with me, and I accept that criticism. As an example, one place where I've seen that regret is for MECP2 and Rett syndrome. It's an interesting and complicated journey for that. For those of you who don't know, those are girls, and they are normal for a period of time and then regress. And I included that, I forced ourselves to include that because I could see clinical trials with genetic therapies coming forward. And so far, the genetic therapies have only come down to age 2. And so there's this period of time when you're sitting on this information and you're hovering and you're watching your child. And that's a challenge. It is a real challenge to do this. So I understand right now where they are in that journey. I totally understand that regret and that challenge with doing this. And I'm holding my breath to be able to see if the genetic therapies are going to help, and then if that regret will continue if they get to the other side of things. So like I said, I understand it. It's a work in progress, and I understand criticism for anyone who wants to put it up both ways. Should we put the cart before the horse or not in doing this? But that's where that signal's coming from.
Alte?
Thank you so much for your important work. I have a question on the scalability of the approach that you're taking. So, and then also I would just like to get your opinion on if this, in the ideal scenario, how would this go? Would this be basically in addition to the regular newborn screening? Would this be compulsory? Everyone would have to do it? And so basically, was it going to be like in 10, 15 years?
Right. If you're going to give me a time frame of 10 to 15 years, I'm optimistic. Optimistic in the sense that someone ought to be doing this somewhere. I'm not going to say for any one place what the value system is and the economics of whether or not they can afford it, but the cost over a 10-year time horizon should come down, the interpretation should scale up, and enough of the public should have heard about this to make the education part of it not that difficult to go forward. On the other hand, I won't say that in 10 years we should be doing the 450 or so conditions we're doing. We're doing this on a research basis to understand of those what subset should go forward. And I anticipate this is going to be an iterative thing. So as an example, you might go for someone, I don't know who, someone might go forward with 25 conditions that are rock solid in terms of the evidence to go forward. You still might be doing whole genome sequencing as a platform to give you the flexibility, but then you would likely grow over time. But I would start in safe territory with things that are robust and reliable to do and then grow, not once you're in implementation stage, assume that you're going to contract or take things on and off. That to me is on the research side. Implementation, you should know what you're doing by then.
Last question here.
Hi, Jason Pinner from Sydney. Thank you for that lovely presentation of your work. I think it's really important. The question I really wanted to know was, as we do more and more genetic testing, we go back, and there are certain areas or certain countries that are actually doing genomic sequencing in pregnancy with no phenotype, so it's a screening situation. How do you think your information is going to be useful to inform reporting of variants, and what lessons have you learned that you think you would like to pass on to those sorts of laboratories and teams?
Yeah, it's a great question, and one that I have to say, because we also do that aspect in terms of the prenatal with no phenotype or with a phenotype, and the stakes to me are even higher at that point because people are making decisions potentially about termination. So number one, I do think to the extent that we can get long-term outcome data, even for people that were not screened positive on this, but to be able to do a lookup essentially, to be able to understand if you see this genotype or variant, can you give any information about this is a normal child going to kindergarten as an example? I think that could be extremely valuable to inform all of us, whether it's prenatal or postnatal newborn screening. So I've been trying to think and starting to talk to our communities about what would it look like to be the next stage in terms of, again, a consented research study to be able to do this, because I do think we need to have unbiased population-based pediatric outcome data. And otherwise, I mean, it's great what we have with the UK Biobank with all of us and other things, but there's survivor bias to being able to get to the age of 40 in terms of doing this. So my plea for any agencies or foundations willing to do this is we desperately need those outcome data. And if we've invested a lot in the sequencing already, to me, it's not that hard to think about getting the outcomes long term to go back full circle.
Well, thank you very much, Wendy, and we're going to finish here. We have a refreshment break in the event space. We'll be back at 11. Also, we'll be announcing the poster short talk prizes before the end of the conference, so please stay until the end. And also for poster presenters, please collect your posters by the end of the conference, otherwise they'll be discarded. And thank you so much again, Wendy, and one more round of applause, please, for Wendy. Thank you.